This one last minute call which I got yesterday at 11:30 p.m. So I will try to do my justice. Orbital tumors, just an overview. So I thought of like orbitis, we know it's a Pandora's box. Here the clinical presentation matters. See, orbital tumors, the thing is nobody will come and tell you I have got a tumor in the orbit, but at the same time in the lid they will come and tell you there is a tumor. So now you can get a myriad of clinical presentation. That's the most important thing. And there are very subtle signs. So if you look at her, she actually was roaming around with a chronic periocular pain. So we treat lubricants, then steroids, this oral NSAIDs, probably ocular migraine, treat like migraine. So then since it was not responding, then we did an imaging, turned out to be a cavernous hemangioma. So this is one very important thing. It's when the patient presents with chronic pain and not responding to a routine line of management, better to get an imaging done. Again, unilateral lipedema in elderly. So if you look at her, you can see this fullness. Look at left eye, and the globe is little displaced down. So this is not allergy. This is an orbital tumor. Again, similar case. Again, he is not noticed. He has not noticed his proptosis. He just came some sort of fullness in the upper lid. Again, this is not allergy. Get an imaging done. So this is another patient. She's already a known case of CA breast, treated long time before, like 24 years back, but she had a mild ptosis. So now the thing is, there was diffuse soft tissue in the supratemporal quadrant. So naturally we can treat it as dacryoadenitis. Since she had a history of CA breast, we thought a little something out of the box. It was a metastasis. Again, with inflammatory symptoms, this we have already seen from Dr. Aparna. It was a case of lymphoma. So I'll just quickly pass through. These are the few presentations. Coming to the neural tumors, this is my first case, this optic nerve glioma. This is a 2-year-old female child with optic nerve glioma. A diagnosis is quite straightforward in gliomas. So initially when the child presented, we thought of observe for 2 months because all the gliomas does not require any treatment. Some of them will spontaneously regress. So they had increase in proptosis, MRI radiologically also increase in proptosis. Meanwhile, get a genetics done for neurofibroma. It was positive for neurofibroma. So since it is increasing, then advised chemotherapy. So by that time, the proptosis has been like this, and the child had lag of thalmos also. So child was started on chemotherapy by the pediatric oncologist, and the child did well. So she's still with us at 3 years follow-up. So the left eye vision has improved to 6/24, even though the disc is pale. So gliomas, if progressively increasing, you have to treat. There are lots of controversies in the treatment because most of the time the patient will be referred to the neurosurgeon. They will directly do the surgery. The thing with surgery is there are some specific indications. Cosmetically differing proptosis, no possibility for vision, and causing gross exposure keratopathy. So with surgery, definitely the child become no PL. But chemotherapy, again, there is a possibility to at least retain the vision. So coming to the schwannoma, again, here the diagnosis itself is very, very challenging sometimes. Most of the time, radiologists will report it as hemangioma. So we also think could be hemangioma, but I will show you this hemangioma will have some characteristic radiological pictures. So treatment is always surgery only. So coming to mesenchymal tumors, rhabdomyosarcoma, the child presented with swelling after a fall. So it was like a kind of masquerade. But if you look at the scan, you cannot see the superior rectus complex separately from the mass. So it is something that arising from the muscle. So we thought of rhabdomyosarcoma, did biopsy and later he underwent radiation also. Lymphoma is the most common orbital tumor, myriad of presentations. So the thing is, our aim is to do the diagnosis, and most of the time it is isolated to the orbit, then do orbital radiation, and they will do well. But the patient has to be kept under follow-up. So this is like, the thing is, we have already seen, like sometimes it starts as inflammation and then it changes to lymphoma. So that is very, very possible. So always keep the patient under follow-up. So this patient actually 7-8 years was on steroids on and off. But if you look at the radiology, you can see this mass lesion, it is actually embracing the globe. So something that embraces the globe is mostly in favor of lymphoma. Coming to lacrimal gland tumors, benign is pleomorphic adenoma. Excision is the treatment. Adenocystic carcinoma, the thing which we cannot miss. You can see why it is adenocystic. There are some bone erosions. Globe indentation is also there. Lacrimal gland is not seen separately. So she underwent excisional biopsy and treatment later. Treatment is by the lateral orbitotomy. Take traction sutures. And muscle sutures are also taken just to retract the globe. Then lid crease with extension to the lateral part. Reach the periosteum. Then I always mark the periosteum. Then incise the periosteum with radiofrequency cautery, or you can use number 15 blade. Put backwards. Then reflect the periosteum. I was using chisel and hammer before, now slowly moved to striker. Now there is a small incision in the fascia. Expose the orbital contents. Look for the tumor. Do blunt dissection. And you can use cryo to remove the tumor and then close it. Coming to secondary tumors can come from eyelid, sac, conjunctiva, then intraocular tumors with extension to the orbit, paranasal sinuses, and metastasis. Everything like once you diagnose, it's easy to treat. In fact, this patient was treated as scleritis, but if you look carefully, there was a globe displacement laterally. So you can see when the scan showed it's a malignancy involving the paranasal sinus. So this patient also very subtle findings only. He had watering, so coming and going with the lubricants, etc. But this proptosis will needs imaging, and again sinus malignancies. Lacrimal sac lymphoma is quite common. You can miss when there is a suspicion of any malignancy, especially when the sac is very thick during DCR. Better to do biopsy, and sometimes you can miss lymphoma sometimes. Metastatic tumors, 8% of orbital tumors, most common in women, especially breast. In male, it is prostate and lung. So this is just an overview of the orbital tumors. The main thing is orbital tumor is diagnosis, because radiology can be like very confusing. So we should be able to learn our own or read our own radiology. That gives the clue. So anatomy is very complex and broad range of diseases, and team approach is always needed. Thank you.
Thank you so much, Marian ma'am, especially helping me at the last moment by accepting the challenge yesterday midnight.